advancements in lower limb prosthetics. We're going to talk a little bit more comprehensively about lower limb prosthetic components in general, but there is going to be stuff on the newer technologies out there kind of throughout this talk. If any of you are going to that DO conference in Philadelphia, the 2 weekends from now or whatever, this is basically going to be a more comprehensive talk than that, but a similar one. So you can go to somebody else's talk. It's going to include pretty much similar stuff. Fortunately, I don't have pictures of this patient, but this is a real patient. This is an 18-year-old female, basically was down at the shore, sustained polytrauma from a pedestrian versus motor vehicle accident back in July of last year. Unfortunately, this poor girl basically got backed into by somebody, by a car, who meant to go forward, but sent her car into reverse by accident. Anyway, suffered bilateral pneumothoraces, hepatic lacerations, retroperitoneal hematoma, had bilateral chest tube placements and XLAP, multiple blood transfusions, also had non-displaced pubic ring line fracture, as well as a crush injury to the left leg, ultimately necessitating a transfemoral amputation, actually pretty emergently. For all this, she recovered pretty well from all the other issues pretty quickly, so relatively uncomplicated transfemoral amputation. So what prosthetic options are available, and how do we choose what's the most appropriate? So that's really the question, right? And with all that's out there, especially with social media, you can see a whole bunch of stuff that comes up, and well, where do you start, and how do you kind of make realistic expectations as far as prosthetic fitting? So objectives, as far as talking about prosthetic components. In past talks, I've talked a little bit about the anatomy and stuff like that, and the surgical approach, but just in the interest of paring things down, hopefully you guys are working on your anatomy knowledge and stuff, and we'll talk a little bit more specifically about that as you rotate through my service. We'll talk about the anatomy of a prosthesis, quote unquote, so the different components that make it up. So you get a sense of the terminology, the difference between the suspension, socket, shrinkers, liners, all that stuff. I'm going to keep it to just transfemoral and transtibial amputations, just because those are what we more commonly see, especially on the inpatient side. More rare, but major amputations are the hip dysartic or the hemipelvectomy. And then less rare, but not really requiring as much tension as far as prosthetics goes are your digit amputations and minor lower limb amputations below the ankle. So we'll review the historical and currently commonly used prosthetic components, discuss emerging prosthetic technologies, and incorporate knowledge of the above to create hopefully feasible and appropriate prosthetic fitting options for our patients. So I have no long idea how long this talk is going to take. We'll take a break at some point in the middle, but get started. So the anatomy of the prosthesis. So basically there are a few different components. There's your suspension, and so very basically that's what keeps the socket on the residual limb. Do not call it the stump, it's not PC anymore. The socket is what interfaces the limb and the residual limb and the prosthesis. And those who are transfemoral or above the knee, you're going to need a knee component. And then there's a shank or the pylon, which is basically just exactly how it sounds, that metal piece, and the foot and the ankle. So this is a basic kind of componentry that makes up your prosthesis. But some of these are not entirely exclusive. So for instance, the shank and the foot ankle system, a lot of those, especially in your kind of more dynamic things that we'll talk about, like your running specific prostheses, especially, those are all incorporated into one piece. There's no discrete shank and foot. Whereas others, it is separate. As far as sockets go for your transtibial, some of these are really more historical, particularly your plug fit socket, whereas in more recent times, and that's a relative term, but in more recent times, there's your patellar tendon bearing and your total surface bearing. We're going to go through each of these. And then your transfemoral amputations, you have your, again, your plug fit socket, which is really more historical than anything. The next step up, which is your quadrilateral socket design, and then your ischial containment and ischial ramal containment, which are similar but slightly different. And then some of the more proprietary and new things which are not quite on the market but are on the forefront. So for transtibial amputations, these are the plug fit socket, and I don't have a great picture of this, but is kind of how it sounds. So back in the day when they made a prosthesis, all they would do is bore a hole into a piece of wood. So it's not anatomic at all, but the patient would fit their leg, their residual limb, into this hole. And so because it's not fit, it's not anatomic in any way, it actually necessitated an additional suspension. So it needed something to keep that leg on. So really it was just a hole in a piece of wood attached to a foot. And then above that, it needed really a thigh corset is what they used. So a corset that fit around your thigh, grabbed above the femoral condyles, had joints attached to this leg. These days, it's rarely seen in industrialized nations for good reason. It sucks. It's terrible. Some of the downsides of this is because it's not custom at all. There may be too much pressure in certain areas and too little pressure in others. So you get edema in certain areas and then skin breakdown or pain in others. Yeah, the suspension itself is cumbersome, heavy, obviously, because it's not the highest tech stuff or the lightest materials. So really, hopefully, you will never see that on a person. So more recent stuff, patellar tendon bearing. And by more recent, I mean within the past, what, 60 years, 50 years. So this kind of became the next popular design in the late 1950s. And this is a patellar tendon bearing socket. And actually, for any of you who've been through my service already, you know that this is probably still one of the main socket types that we use. The idea with this patellar tendon bearing socket is that you load pressure tolerant areas, which generally tend to be your soft tissue areas, while relatively unloading those pressure intolerant areas. So places where the nerve is very close to the skin, like the perineal nerve, bony prominences like your fibular head, and we'll just see quickly where those areas are. So the patellar tendon bar is one of those. The patellar tendon is one of those pressure tolerant areas, and it doesn't bear all of your weight, but a good portion, so 30 to 35% of that weight. So that's why we call this a patellar tendon bearing socket. Still, even though you're loading some areas preferentially and unloading others, the idea is that you still maintain total contact, because pressure in the residual limb or anywhere really is inversely related to, inversely proportional to the area of contact, right? So the smaller area of contact, the more pressure, and vice versa. So your pressure tolerant areas are your soft tissue areas, like we said, patellar tendon, pretibial muscles, the popliteal fossa. Lateral fibular shaft is really the only bony area that's listed, and that's because it has pretty good soft tissue coverage, and it's along the length of that. So, if you look at this cartoon, then basically this computer-generated image shows that it's pretty contoured, right? It almost looks like a cast of the residual limb. So it's pushed in those areas where those pressure-tolerant areas, as indicated by those orange spots and lines over there, okay? Pressure-sensitive areas, again, your bony prominences, so tibial crest, tibial tuberosity, fibular head, patella, distal patella, hamstring tendons. So obviously, there's not a whole lot of real estate there. Transtibial, those pressure-tolerant areas can be fairly close to those pressure-intolerant areas. So casting has to be pretty precise, and so does fit. So just keep that in mind. Okay. And again, just a picture with the red now indicating those pressure sensitive areas that you're trying to avoid. So if you look at this socket here, the only reason I included this picture is because it has a good picture of the posterior trim line, so the back of the socket. And if you look over here, you can see these channels where they actually kind of provided pressure relief to those hamstring tendons. And there's not enough relief, you definitely can get skin breakdown. I've seen a few patients with that. Conversely, it's actually kind of pushed inward a little bit here at the popliteal fossa because that's a pressure tolerant area. It also pushes the residual limb forward, so it improves your contact with that patellar bar a little bit. PTB socket variations. So these are the supracondylar. So if you look at the picture on the left, you see those lines that come up a lot higher. This pocket looks deeper. So it's not that this is deeper, but these walls are actually higher. And then the supracondylar, suprapatellar, which not only goes above the femoral condyles a significant amount, but also goes above the patella. I've never seen these in real life. I've seen them in these pictures exclusively, but they do exist, and they exist for a reason. You know, one is that, that if you have a significant amount of medial lateral instability or a short residual limb, raising the walls helps deepen that pocket and give you that stability. In the case of the supracondylar, suprapatellar socket there, it can help prevent Recker bottom. So the good thing is stability. The downside is that it's big, it's cumbersome, and cosmesis is a big issue. And you know, I think a lot of us kind of put cosmesis at the wayside because we're all interested in function. But you think about it, if something's not cosmetically acceptable to a patient, they're not going to use it. So the problem with this is that it extends so far up above your femoral condyles that when you're standing, it's not a huge deal. But when you sit down, those borders raise higher than your thigh, and so it's pretty noticeable. Like I said, I haven't seen too many of these, or any of these really. So about 30 years later, there was this kind of development in the socket design, and the idea was, well, instead of kind of putting more pressure over your pressure tolerant areas and unloading those pressure intolerant areas, well, why don't we just create a socket that really just evenly distributes the pressure everywhere, right? So the idea is you create the socket that, you know, if there's even pressure everywhere, then no one place gets too much pressure. And so this is the total surface bearing socket. What you see on the left-hand side is, it's called a check socket. So it's a socket that the prosthetists initially make when they're fabricating a prosthesis, just to make sure they get the fit right. It's easily moldable, it's cheap, but it's not meant to be your permanent socket. Nonetheless, I included this picture here just because it's a good example of this, the contouring. You can see it's relatively smooth compared to that patellar tendon bearing design where you see all those buildups and pressure reliefs. And then this is just a picture showing that pressure. So that's transtibial sockets. Just moving on to the transfemoral. So again, the plug socket, same thing as a transtibial. And here's an actual picture of this wood plug socket. So it just looks like a hole. Pushing into this tends to displace your tissue forward or upwards. And so a big problem was getting what's called an adductor roll. So this pinching of the soft tissue in the inner thigh, which can be quite uncomfortable. Really just as bad for transfemorals as it is for transtibials. And only really in developing nations, hopefully. And hopefully not even there. So the problem with the transfemoral amputation, and I just realized I kind of skipped over knee disc artics, but anytime you cut through the bone, right, you're not meant to distal end bear because that's not how the bone is designed, right? So anytime you have the full length of bone, the advantage is you can put all your weight through it, or a good amount of weight, because that's how the bone was designed, is that designed to take weight that way. You cut through the femur, well, now you have this sharp, bony, small surface, and and it can actually cause a lot of pain. It can punch through the soft tissue, cause skin breakdown. And so the idea with the transfemoral is that you need to find a way, and with the transtibials, you need to find a way to offload that distal residual limb so you don't get too much pressure there. And so how do you do that? Well, in the 1950s, they took it past the plug fit socket, and they decided to make something called the contralateral socket. So the idea of this, again, is this total contact idea where you get principle where you hopefully reduce the pressures in any one area, but then there is this ischial seat, which if you look here, it's kind of a grainy photo, but it's basically you're sitting on top of this socket. And so it's this horizontal shelf that your ischium sits on top of. So you're literally sitting on the top of the socket. The way you're kept on that seat and the ischium is kept pushed back onto that seat are these bulges. And so this is what's called a scarpus bulge. And so it's this kind of triangular bulge within the socket that actually is over the femoral triangle and helps push you back onto that seat so you maintain that and you're not moving around. What characterizes a quadrilateral socket, as the name implies, is that the kind of square-like shape or the quadrilateral shape, and for relatively normal body habitus person, that's not terribly anatomic, right? If you look at a cross section of our thigh, it's actually longer AP and narrower ML. But nonetheless, it was made like this. It pushes in so that you can push the leg back onto that seat again. That bulge there also keeps the socket from rotating too much because if it's too round, there's no contouring. It can kind of twist as you're wearing it. So here's another kind of cartoon representation of that. So if you look at the pelvis, the ischium as well is above the actual trim line of the socket, and you're sitting on top of that. So really the kind of defining characteristics of this quad socket are narrower AP dimensions, so it's just about as wide AP as it is ML, or even or ML as it is AP, or even narrower AP, and then this horizontal ischial seat that you see here. Again, this is just a check socket kind of demonstrating that, so you can see how horizontal that is. It's relatively square in shape. And here's that scarpus bulge that we talked about, which sometimes is a little bit more prominent. So the problem with this socket is that, yes, you did offload that distal end, but because you're kind of sitting on this socket, there's a lot of problems with ML instability, and particularly hip abduction, right? So as you go up in your transfemoral amputation level, you lose your hip adductors the further and further up you go. So you have relative sparing of your hip abductors while you have your hip adductors being lost, right? So it becomes more of a problem the higher up you go. And so you end up walking like this. The other problem was no matter how good that ischial seat was, you're sitting on top of it and you try to contain it, but you end up, the complaint was that there's discomfort, you're sliding all over that seat, you're kind of going back and forth on it. And so it was not a terribly stable design, this quad socket. And so in the 1970s, the ischial containment socket was developed in order to deal with those issues. And so if you look at this cartoon, the lateral wall is quite a bit higher, but really the prominent characteristic here is that it's trapping your pelvis. Your pelvis is actually sitting within this socket. And so in that way, you actually have 3 points of pressure here. If you remember at your gait and orthotics course, you need that in order to stabilize a joint or control motion. So you would have something proximal. So here's your two counterpoint, your points of pressure, and your counterpoint is within here, pushing you into adduction, which is your more normal anatomic position for ambulation. The ischial containment socket, if you look at the literature, is called a number of things. Obviously, ischial containment, narrow ML, because this is in comparison to the previously existing quad socket. The CAT-CAM socket, which stands for Controlled Adducted Trochanteric Controlled Alignment Method. It's a long acronym. This is not to be confused with CAD-CAM, which is used in manufacturing. And we'll talk about that later, actually. But that's a different acronym. Normal shape, normal alignment, and then Sabolic. So those are names for that. So despite being developed before I was born, before most of you were born, except for Mike. Sorry, Mike. It's still really the predominantly used socket. This is where he gets up and he's, I guess, crap. It's still one of the most popularly used sockets to date. Really, the majority of our patients have this ischial containment design. Kind of stood the test of time, at least in comparison to the quad socket. But we'll talk about that in a little bit. So if you compare this to the quad socket design, you see it's much more narrow ML. You can see that lateral wall is quite a bit higher. And you probably have to think back to this picture, but you see how horizontal this kind of seat is here, this shelf, and you look in comparison here, it's quite a bit more vertical, and so that it's not a shelf that you sit on, it actually is just a lip that actually contains the ischium to keep your femur from abducting. The next step up is then a similar design to the ischial containment socket, but this is something called an ischial ramal containment socket. So the problem with the ischial containment socket, which, you know, if you ask any person with a transfemoral amputation, is that one, it can be uncomfortable, but two, it also can kind of restrict your motion, because those trim lines, so by trim lines I basically just mean the borders of the prosthesis. So medial trim line, posterior, lateral, it's just the margins. They have to come up quite high, right? And you do that because you need it for stability. So it needs to come up into the groin. It needs to come up all the way over. On the side, it needs to come up fairly high in the anterior groin as well. And in this design, the ischial containment design, comes up quite high underneath, right under the gluteal fold. So your body weight support is actually coming from, you know, not only a little bit of this lip where part of your weight is borne through the pelvis, but also through the gluteal area. So the problem with that is that it restricts your motion, right? You can restrict your range of motion, particularly for extension and flexion. When patients sit down anteriorly, you know, it pinches in on their groin. And then the inside, everybody's complaining of pain on the inside of their groin with the socket. For most people. And usually that's something we manage with socket fit, making sure that their sock ply is adequate, things like a softer inner liner. So this addresses this fellow, Marlo Ortiz, who's a prosthetist, decided that he's going to keep the ischium contained so that we have that, that control, but the you're going to bear weight, a lot more weight through the ischium and the pubic ramus, so almost exclusively through there. So he actually moved that lip a little bit medially, and that allowed him, if you bear more weight through there, to completely create this channel behind the gluteal fold over here. So this is quite a bit lower than the other design. The other aspects of the socket are fairly similar to the ischial containment design. This is newer, probably within the past 10-15 years or so. And I've seen it in some, and so you can see here it's even more dramatic. This cutout is quite big, but what they did is they put this soft thermoplastic inner liner, so you have a little bit of support, but it's a little forgiving, and it gives you a little bit of padding. And you can see this range of motion is, you know, if you've seen other people with transfemoral amputations, it's pretty impressive here, but also for extension, because now you have that cutout in the gluteal area. Studies have shown that it does improve that range of motion. But just anecdotally, this looks incredibly painful. I mean, patients already complain of groin pain with the ischial containment design. Well, now that you're completely bearing weight through the ischium and the pubis, and it's even more medial, it kind of cuts into their groin even more. And so I haven't seen really a single person with this design that hasn't complained of some sort of pain, understandably. But I also haven't seen too many people with this. With the socket. Like I said, the vast majority, probably 90% or more, have more of an ischial containment design. Just a comment, so I'm introducing all these things as completely separate designs, but actually there are quite a few that kind of overlap. And so there's an ischial containment socket. Yes, there's an ischial ramal containment socket. Yes, there's a quad socket, but sometimes they're actually sort of hybrid designs of either. So there's a little bit of, you know, like a hybrid design between a quad socket and ischial containment, where there's a little bit more of a horizontal lip, but it still contains the pelvis a little. So just keep that in mind. So more recently, and I don't know when this is developed, but this is just one company out there. There are no studies behind this, but this is what's called a high fidelity socket by a specific company called Biodesign. So this is a proprietary design. This is basically something that actually prosthetists have to get pay royalties to this company for and learn their casting method and stuff like that. But the traditional sockets, you know, ever since the quad socket, are actually created by casting, right? So, or measurements of that residual limb. And so what you're measuring is actually the soft tissue around the bone. Well, this company thought, well, that's ridiculous. What we're going to do is actually we're going to try to capture the femur as best as possible so that that movement is very intimate. And so in their casting mechanism, they basically press in as much as they can these kind of relatively pressure tolerant areas and create 4 struts, and that allows them to make these big windows, but it also allows them to get down as close to the bone as possible. And so with that, with it fitting better, their proposed benefits are that it reduces motion between the residual limb and the socket. Because of that, because it's so intimate, it feels like it's moving with you, so it feels lighter. There's better range of motion, and it's ultimately more energy efficient as well. Again, this has yet to be proven. This is just our design. But you can see how different it is as far as this versus a full kind of laminated socket all the way around. And this is kind of just these are pictures of just their casting design. So they actually would push in with these metal bars on the patient's leg in order to make this cast. They create a cast on there. So you can see, it actually pushes in quite a bit and tries to capture the femur, which is what you see here. And then you ultimately come with this time. There's still initial containment piece, and then this doesn't account for suspension either. So there's that design. And this is really pretty recent also. This is a company called Limb Innovations. And their idea was actually to make, instead of a socket that is custom made for each patient, is to make the socket adjustable. And so if you look at their design here, all this stuff is adjustable. You can see these straps. The proposed benefit for this is you can adjust for the residual limb size depending on just the day, and you can tighten it up just like you would like ski buckles or anything like that, or a shoe or something like that. So if you're more swollen one day, well, then you're fitting in for that fit that day. If you're less, then so decreases your need for socks, provides you a more intimate fit. It's adjustable, and so it's also a cost issue, right? If you can provide somebody this socket and it lasts them a couple of years versus getting them a socket that they quickly shrink out of, and then you need a socket replacement, they need to get recasted. You go through 3 or 4 of those, theoretically this could cost less and actually even be more comfortable. I actually don't know that this has yet to hit the market. I've seen proposed stuff. And so here's just a cartoon representation of that. So these are these carbon fiber struts that again are connected by these straps. They offer a number of different ischial seats so that you can find the one that best fits the patient, and you can adjust the height of it. So again, that you're offloading that distal limb. So it's quite a different design in the sense that it's not custom, intentionally not custom, so that it can adjust to each person and their own changing volume fluctuations. So those are sockets. So suspension. Suspension, again, is what keeps the residual limb. Any questions about sockets, by the way? No? Not good, huh? Suspension. So suspension is what keeps the residual limb, or the prosthesis on the residual limb. And there's definitely more than one way to skin a cat. Some of these are more historical than others, but even the old designs we can use on occasion if the situation warrants. So here's just a list of these for the transtibial, the corset, the supracondylar strap, anatomic suspension, pin shuttle locks. Some of these are similar because there are similar suspensions used in both transtibial and transfemoral. For the transfemoral side, the Silesian belt is probably the oldest one. Moving on to other belt systems, and then your lanyard, which is probably one that I most commonly use. Not even probably, I do. The pin and shuttle lock, which I use more for transtibials and transfemorals. And then your suction suspension designs, which there are quite a few flavors. So the transtibial, the thigh corset. So this is kind of what originally, one of the first suspension systems. It's fairly similar or simple, just like a corset that was worn, women back in those archaic days to make them look thinner. The idea is the same. There's straps that either straps or buckles that go above the knee, and you just tighten them, and so you're actually basically bearing weight. It helps to offload the distal residual limb. It keeps the leg on, and this was pretty much necessary for that plug fit socket. But even once the patellar tendon bearing socket design came, you do use it for that. I have a couple of patients in this. Nowadays, it's not something I like to use too much because obviously it looks pretty cumbersome. It's big, it's heavy. Those straps, take forever, especially if you have poor hand function, like many of our diabetics do with neuropathy. But it has its uses. I mean, if somebody has a lot of distal residual limb pain or a wound and you really want to offload it even more than that patellar tendon bearing design, this can help you offload it more, right? Because it's kind of conical in shape, sort of to match the shape of your femur, and so you're sitting on that. So you're actually suspending above the level of the knee. So it can help offload that residual limb more. Also, you see that this necessitates a joint, right? So, or actually 2 joints. So you need those hinge knee joints. So it gives you a level of ML stability that is somebody who's either lax or just has poor ML stability for any other reason. This can help stabilize that joint. The other thing that you do, I have one patient that we just saw in clinic recently where he had a lot of knee buckling. Even though he was a transtibial, he had pretty weak leg, quads, had a significant contracture, and so he was always being kind of pushed into a knee flexion. Or just couldn't handle that knee flexion moment. And so we put drop locks on his corset. Drop locks meaning that there's a lock that goes on either side of this joint. They sit down, or they're sitting, it's unlocked. When they stand up, those locks drop around that joint to keep it in place. So that's another reason that you might use it. Moving on to strap suspension. So another idea, and again, this is fairly old, but are using straps to grab above the level of the knee in order to suspend that prosthesis. And so one is a supracondylar cuff, which you see on the right here. And so basically the strap just goes behind the knee or behind the thigh above the level of the femoral condyles. You tighten it, and that's what keeps the leg on. Alternatively, you can use this waist belt that has this, what's called an inverted Y strap, because it looks like an upside down Y. That helps just suspend it from the waist, or you can do both. This particular system has both. It's pretty easy to put on. You basically just need basic grasp, or if you can buckle a belt buckle, you could probably do this. It can accommodate for volume fluctuations pretty decently. Disadvantage is that it's not the greatest suspension in the sense that it allows for more residual limb motion within the socket, right? So since you're grabbing above the femoral condyles, every time I take my weight off there, it's dropping down. It's just waiting to catch on your femoral condyle. And you push in, and then it pushes up because there's nothing suspending. So you kind of have this motion that's not so well controlled. You get this kind of pistoning effect, which can cause discomfort, but also can functionally lengthen the limb, particularly in swing, right? So if it's drooping down, you try to swing your leg and it catches because it's just hanging off your femoral condyles, and it's actually functionally longer, that limb, than it is when you're standing and bearing weight. So moving on, the anatomic suspension, if you are paying close attention, is the exact same slide that we talked about for variations of that patellar tendon bearing socket. So this is actually not just a socket, but it's a suspension as well. And so anatomic suspension just basically means that you're using the body's own anatomy in order to help suspend that, so you're not relying on straps or anything else. In this case, the femoral condyle. So if you look at this, and you look at this picture here, it kind of bows out to allow the femoral condyle, but then it kind of narrows above it, right? So you push into it, it's a little tight once you push in, but once you're in, it doesn't come off because it's catching on your femoral condyles and keeping it from falling off. So the nice thing is ease of donning. You push in if this is fitting properly, and then once you're in, and then you pull out just a little bit and you're out. Again, I've never seen these in real life, but I imagine that the issue is the same, that it allows for a little bit more pistoning, less kind of intimate contact between the residual limb and the socket. And then as technology advanced, you have what we see most commonly on the floors. You'll probably see this more than any other type of suspension. And this is what's called a silicone suction suspension, or just a gel liner, or 3S system, depending on who you talk to. And so this is basically a gel liner that comes in direct contact with the skin. This is actually considered partial suction, which I don't really agree with. Reason why it's called that is because as you're rolling it on, the technique is that it's a gel liner on the inside. You completely invert that liner so that and then you kind of roll it up your leg. And so that direct contact between your leg and the liner basically pushes all the air out. There's total contact between this liner and your skin, and so now it won't come off because you have this vacuum. Reason why I don't consider this a vacuum suspension necessarily is because, yes, it's what keeps the liner on you, but it's not what keeps the prosthesis on the residual limb. So you still need a suspension to keep that. So basically, if I'm using a pin or I'm using any of these, I'll call it that. I'll call it a pin suspension system. So having said that, on the end of this liner, there's a pin. And this pin basically fits into a shuttle locking mechanism that's in the socket. So the patient pushes in, that clicks into that socket. Want to get out of it, there's basically just a release on the side of the socket. They press a button and they come right out. This is probably my go-to for transtibial amputations because of a couple of reasons. One is ease of donning. So once this liner is on, basically all you have to do is push in with a pin. So the patient can use their body weight in sitting. They fit the socket on, line up that pin, and they just push in with their leg. Right? So it's relatively easy to put on versus some of the other suspensions that we're going to see later on that you need quite a bit of hand function in order to get on properly. The other thing is, as you're in the socket, your residual limb can shrink. And so what we teach the patients how to do, and they need to be proficient in, is managing how many socks they need to put on, because those are what we use to kind of fill out that negative space if they shrunk down. The nice thing about this is you can fit a full-length sock on here. You can go all the way up, and so you can control for kind of global residual limb volume loss, which is not really possible with some of the other suspension designs, or even this magnet design that you see here. So this one is a magnet suspension system. I think one prosthetist developed it. I've never actually seen this either. There's a little bit of literature on it, but it's not widely used, at least to my knowledge. But you can imagine you can't put a full sock on here because then it just gets in the way of the magnet. Right? So disadvantages. Anytime you have these gel liners, which again are really popular these days, you can have issues with sweating because they're not terribly breathable, skin irritation, and then with the pin particularly, it can cause distal residual limb pain. Or make it worse if somebody has distal residual limb pain. So that's a relative contraindication to using this suspension system, or why I would actually think about switching somebody from this. So what happens is, you're suspending the residual limb from this really focal point here. So you're doing that. When you're standing, it doesn't really make a big deal because you're standing. So you don't need a suspension if you're just standing, right? But where it comes into play is when you're swinging. If you swing like this and you're pulling from a pin each time, you get this milking effect on the distal residual limb, which can be painful. It can even cause blistering sometimes if it's not properly put on. Somebody who has a wound that can make it worse. So I have switched people out of pin suspension systems when they've developed issues like that. Now switching over to the true vacuum suspension systems, and so this one is probably the oldest, and this is what's called the external sleeve with an expulsion valve. And so basically what you're doing is the socket actually has a small hole at the bottom of it with a one-way valve that lets air out. And so when the patient pushes their residual limb into the socket, it pushes air out of that valve. And then you're creating a seal by having this sleeve that fits half on the socket and half on the skin. So that sleeve actually has to contact the skin directly to make that seal. And so now that you have that seal there, it won't let any air in. So that vacuum is what keeps the residual or the prosthesis on. So it's not actually the compression or the circumferential compression from the sleeve itself. That's not the primary method. It's that vacuum that keeps it from coming off. the older designs are made from neoprene. I have seen these external sleeves made from gel as well, quite commonly. And these days, basically, what is put on is basically a gel liner that fits directly onto the skin, kind of like what we saw here, but no, without a pin on the end. So it's just a gel liner all the way around. The patient will put on whatever socks they need, fit their residual limb into the socket, and then roll this sleeve up. So the advantages are it's lightweight, it's relatively cosmetic, it's strong. You see this is probably a promotional picture from a prosthetic company, but this guy's handing off of monkey bars with this, so that's how strong the seal is. I would not recommend people doing this. But like anything with a gel liner or anything with where the skin's completely covered, you can get perspiration. And the other problem is that why this isn't my go-to is that you need a good amount of hand function in order to do this. So like the like any sleeve that you're rolling up residual limb, this you actually need to invert completely or invert off of the residual limb and just on the socket. You need to actually roll it up your thigh, right? Kind of easy to do with a gel liner because they're sticky and you can pull them off and whatever, but especially with these neoprene sleeves and things like that that aren't so sticky, if somebody has poor intrinsic hand muscle strength, well, then basically I can't extend my fingers all the way and do this. Like I can't grab like this and pull, which is what you need to do in order to pull a sleeve on, right? What ends up happening in somebody, say, with diabetes and peripheral neuropathy, their hands, they can't do that, and they end up going like this. They have poor contact, and they try to go like this. They can't get a good grip on it. You can't just grab the sleeve and pull it up because it'll fold over itself and catch, and you won't be able to get it on. Or if you do, it'll be incredibly difficult, and it might not get the contact that you need. So for somebody with poor hand strength, either from diabetes or a stroke or anything like that, this is not a good suspension system to use unless you have somebody that can actually help them put it on. So that's that. And you can see if it's flesh toned or whatever, it can actually be fairly cosmetic in the sense that it looks a lot more like a natural one. So a newer type of suspension system, and I think Osser is the only one that makes the ceilin design. Basically, it utilizes the same kind of socket where you have a one-way expulsion valve, and you can see that in this this cartoon over here. Except the seal, instead of being formed with an external sleeve, is actually formed with between this liner. And what this liner has are these either one or multiple circumferential ribs that are made out of like a rubber-like material, which make total contact with the inner margins of the socket. And so as you push in, it pushes air out of that valve. And because it's a one-way valve, it doesn't let air back in, and so that's what keeps it on. So that vacuum is between these ribs and the end of the socket. So not quite as focal as your pin suspension. So in somebody who has that, you might want to switch them out to something like this if you think they're a good candidate. Advantage of this, it's a great suspension system if that vacuum is working. Keeps it on just as strong as any. There's less motion, even in studies it's been found that with a ceilin system there's a little bit less motion between the residual limb and the socket than even a pin, which doesn't have that much motion itself. Yeah, basically they're good suspension systems. And it can be coupled with another suspension system which we'll talk about in a little bit. The downside, so if you look at how this works, you're pushing air out and you're forming a seal between this ribbing and the end of the residual limb. Well, it's fine if your residual limb is stable, but like we said, we use a lot of sock management or whatever for people with fluctuating edema. This is not great for somebody who has fluctuating a residual limb volume. So people with CHF or people with end-stage renal disease are on dialysis. Obese patients, they can have a lot of variability in the residual limb volume. The reason why it's not good is because I can only really volume control up here. I can put socks on up to here, but if I put a full-length sock on, well, it's going to break that seal, and so you won't have a suspension system. So the only socks that exist for this are these kind of half socks that go up to here. So if I'm too loose at my distal end, well, I'm kind of screwed. I can't put a sock on there. As a stopgap measure, what some prosthetists tell the patients to do is actually put like a half sock on directly onto the skin and then fit their leg into the liner, but still that's not ideal. So somebody needs to be really stable. So generally, one, I never use this for somebody's preparatory prosthesis, so the first leg that somebody gets when they start walking, because their residual limb volume hasn't matured yet. Most people shrink down. So I would never start off with this system. I've come into too many problems where people come in with them and right off the bat we have fit issues. And two, if I expect that their volume is going to be fluctuating too much even down the line, this isn't something. So I don't use this very commonly just because the patients that I have are mostly, like most of the patients in any developed nation, are amputations due to disease, not your young traumatic patients who are, really otherwise healthy. So that's where I would use it. I would use it in somebody who is, relatively young, active, really no volume fluctuation or very minimal, because this is such a great suspension system. The other thing that's good about this is, as opposed to the pin, is that the pin you actually need a bit of space, right? So there's that shuttle mechanism has to fit into the socket. If somebody's residual limb is so long that, that shuttle now, the residual limb is this long and you put a shuttle on there, well, then the knees aren't going to match up, right? So you need the amount of space for that. So this is shorter. You don't need as much space in the socket, so that's another advantage of this. All these gel liners, by the way, you need to actually, skin hygiene is extremely important, which sounds, like a no-brainer, but anybody spends a month or two on my service, you realize that some people have terrible, terrible hygiene. These liners need to be cleaned every day, usually mild soap and water on the inside to be wiped out. And so patients need to keep up with that, as well as cleaning their own skin every day. So somebody with poor hygiene, not a great thing. And then finally, the vacuum-assisted suction suspension, or VASS system. So this is just kind of an additional suspension system. It works like with those other vacuum-assisted, in the sense that there's a valve, except instead of just having a one-way valve that's passive and you push the air out with your residual limb, well, this is an actual active pump that connects to that valve and actively draws more air out. Okay. So we've talked a little bit about sock management and stuff like that. Sock management traditionally has been a necessary thing, because without a vacuum-assisted system or these newer technologies, you fit your limb into a hard socket or a cast or something like that, and that just shrinks down your limb volume. It just pushes fluid out. And so you have to adapt to that, or compensate for that by putting on these socks. You get to a certain point, yes, you can fit in, you put on more socks, and yes, you can fit in, but then that motion between the socket and the residual limb, you can't account for that, and you still become unstable. So this kind of takes the opposite tack by actually putting negative pressure on containing the residual limb, putting negative pressure on there. It actually draws air out and brings the surface of the skin to the socket wall, and so it actually expands the residual limb volume size to match to meet the socket walls. And so in that sense, it actually reduces your the motion. It's a very intimate fit, so that socket moves with your residual limb. There's less motion between the socket wall and the residual limb, hopefully less pain. This is what they theorize, and actually it's been shown to be true. This is the least amount of motion with this negative pressure system. What's not so established is whether that actually makes a clinical difference as far as comfort or performance. And so there are a number of insurance companies, well, one in particular that absolutely outright refuses to cover this, because they say, like when they refuse anything, that it's experimental, it hasn't been proven, yada, yada, yada. Nonetheless, it's a good suspension system. Again, it's added to that. So this is something that could be added to something like a ceilin suspension system, like we saw before. So here, instead of it just being a passive valve, you just add this pump, this vacuum-assisted pump. And that pump can work in a number of ways, right? So one, you can actually just have a manual pump to just draw out more air, and then you just leave it at that. Or you can have a pump like this, where it's actually built into the foot, ankle, or the heel component system, or the pylon, so that when it compresses, it draws out a little bit of air each time you take a step. And then finally, there's actually ones that are battery operated, which is what you see here, where it's just actively drawing out that air. So the advantages we talked about, disadvantages, it's not always covered. It can be heavy. And depending on the type of pump, if it's manual, you might need some good hand function for that. But I don't think I've actually seen a manual pump design, to be honest. I think they're usually built into the system. So there's that. You guys want to take a little break?
Assisted, do you ever find that it's overly sucking on the leg and it's causing like edema or something?
Well, I mean, the kind of idea is that not necessarily edema, but it increases the residual limb volume size. There was something else I forgot to mention, but yeah, I have had a patient or two that's complained of pain, and so we actually just cut off the thing and just changed it to a regular passive system. But just another point on the negative pressure. So there's also talk in the literature of it kind of working like a wound vac, right? So wound vac works on negative pressure. It draws blood into the into the wound bed, which promotes healing. And so there's a suggestion that somebody with a vascular or a residual limb wound, you put something like this on them, it can actually help with the wound healing. Studies haven't necessarily shown that, but what the study has shown is that at least one particular study is that there does no harm, right? It doesn't actually make this wound worse. So having a wound is kind of stinks, and there's no standard of care as far as treating a residual limb wound and allowing ambulation. But a lot of times what we do is because we're so concerned about skin, especially in diabetics or dysvascular patients, is that we just offload the limb completely. And so at the we focus on their skin care at the expense of their mobility, and so they can get more and more decondition and things like that. Well, in this sense, you can actually keep somebody depending on where the wound is and how it is. You can still keep them weight bearing, and you can have them use their prosthesis, but still allow for wound healing. So that's what this one study suggested. And then there are other studies that actually did suggest that improved wound healing. It's kind of up in the air, but none of these studies are very high power, unfortunately, for prosthetics in general. Let me see where we are as far as the slides. I'm sorry. Oh boy. Okay. So I think we're just going to get through transfemoral suspensions, and we'll take a little break. Okay. So the transfemoral suspension system. So the oldest one is a Silesian band. Don't ask me what Silesian stands for. It sounds like a country, but. Basically, you're fitting into a socket and you need something to keep it on. And so the simplest thing was this belt. And so this belt basically just attaches on both anteriorly and posteriorly or there's a buckle anteriorly, and the belt kind of wraps around your contralateral hip, and then you just buckle it in. This is the oldest design. It's pretty simple, right? The advantage is that it's not expensive. It's pretty easy to fabricate. It's just a belt. And it's easy to don. Disadvantage is not a great suspension system, right? You're just kind of hanging off your other hip, and so you can have those those issues that you have with other strap suspensions, where it's just kind of dangling when you're non-weight bearing, and then you just sit into it when you're weight bearing. But if you look at where it is, and one of the big problems we talked about was the hip instability. So a large problem with a lot of transfemoral amputees is what's called this lateral thrust, where every time they're taking a step, the lateral portion of the socket gaps. You see kind of this, right? So in somebody that has that persistent problem that you can't address with fit and with alignment, this might be a good option just to help draw that proximal portion of the socket in towards the body. Pelvic band, again, similar idea, except this incorporates a joint. So somebody with hip instability, this might be an option. The one patient I have this in is actually a hip dysartic, but he had enough soft tissue that we created like a transfemoral socket for him. So even though we kind of had this transfemoral socket, he didn't have a hip joint to speak of. It's kind of odd, but it worked out, and we just gave this. So we basically created this external hip joint with his residual tissue is actually in his core musculature is actually able to advance the limb. So he was kind of more functionally a transfemoral than a hip dysartic. That's the one patient I've had this in. Otherwise, it's a fairly old design that we don't use terribly often. Same advantages as far as like controlling that lateral thrust if you can't control it in other ways. And then another belt system. This is just called the total elastic suspension system. It's neoprene. It's soft. I hate it. It's terrible. Don't use it. It's so compliant that it doesn't really give you great stability. The only thing is that it's pretty easy to put on. It's fairly comfortable because it's a soft belt. But I would never use this as a primary suspension. It just sucks. It doesn't control anything. As far as motion, it kind of keeps the leg on, yeah. But some of these suspension systems actually can be used as a secondary or auxiliary, so you don't have to just stick with one. You can double up. You can have this as well as another suspension system to provide a little bit more stability. And then going to those other designs, this is basically the same thing as you saw on the transtibial side. So you have the silicone suction suspension. And you can have a pin, like we do with a lot of our transtibials, but then you can also have this lanyard system, called a lanyard because there's a strap or a lanyard that attaches to the distal end instead of a pin. And basically there's a hole that's built into the anterior, usually anterior part of the socket. And so you actually draw yourself in with this lanyard, you pull yourself in, and then you feed it through this buckle here, and that's what fastens you in. Same advantages as far as you being able to put on full-length socks. And an advantage of the lanyard over the pin suspension, especially in transfemorals, is that if you have a longer residual limb, you don't need as much space in that socket to fit the suspension, whereas you need a good couple inches or more to fit this shuttle for the pin. This is actually one of my go-tos, at least initially, for somebody's preparatory prosthesis, again, because it controls for volume very well. But it's also something that you only need, a gross grasp. It's pretty easy to pull into, right? So all you need to do is feed that lanyard through the strap, you pull yourself in, and then you're in. And you might not be all the way in, but at least you're secured, and then you can stand up and fasten it somewhere, right? So relatively easy. I don't like the pin suspension system for the majority of my transfemorals because majority of patients with transfemoral amputations, again, if you've been through my service, you know this, have some degree of hip flexion contracture. And some of them are pretty significant, where you do a Thomas test on them and their hip flexion is, this is as far as they can get. And so if you're trying to push into a pin, if you have no contracture, it's no problem because I can stand up straight, I can open up, and I just put weight on there and I'm fine. If I have this hip flexion contracture like this, well, now I'm trying to stand up, the knee's not locked out, I'm trying to push obliquely. And so you're just asking to fall or just not be able to get in there with a pin. And so unless somebody's range of motion is really good, I tend to stay away from that pin for the transfemorals and stick with the lanyard. And then moving on to the vacuum. So one thing that's different with the transfemorals is that there's enough soft tissue that back in the day, people used to just fit what's called traditional or direct suction, where there's no barriers, basically just a skin socket interface. So you actually fit your skin directly into the socket. There's a little bit of buildup here for a little bit of cushioning. It's a vacuum system, like any other vacuum system. As long as the vacuum is working, it works great. There's direct skin to socket contact. The disadvantage, an intimate fit, and so because it's a vacuum, there's not that much socket residual limb motion, right? And believe it or not, this can be comfortable for some patients if it's fitting right. The idea of me fitting into something like a hard socket just sounds uncomfortable. Believe it or not, some people prefer it. Disadvantages, it's difficult to don, and we'll see in the next couple of slides what that donning technique is. And the big one for our patients is not adaptable for girth fluctuations, residual limb volume changes, right? Because if you lose weight or your residual limb volume is down, well, then you're not creating that vacuum because there's space, there's air between your residual limb and the socket. So really the only time I use this is in patients, because there are newer suction systems, even for somebody with stable residual limb volume, stuff like the ceilin that we saw with the transtibials. Unless somebody is like a remote traumatic transfemoral amputation who's used to this system and likes it, I'll generally try to use something else like a ceilin, even if the residual limb volume is stable. And it's terrible for any new amputee or somebody who has a lot of fluctuation in their volume. So donning technique for this, basically there is a valve, but this valve cap is completely removable. And so what you have to do is, because it's such intimate contact, if you're just to try to put your residual limb into the socket, there's so much friction that you wouldn't be able to get in, you wouldn't be able to get total contact. So there are a couple of different methods to get in. And one is actually drawing yourself into the socket. In order to do that, there are certain things. So you can either use tuba grip or a sock or this nylon parachute. And what you actually do is you actually put it on the residual limb, put the one end through this valve after removing the cap, and then you just pull yourself into the socket, keep pulling, pulling, pulling until all that material is out. Once all that material is out, your leg is all the way in. And then you basically just turn the cap, and that creates a seal. So that's one suspension, or that's one method. The other is this wet fit, which basically you're reducing the friction by spraying your leg, usually with some sort of alcohol-based spray in the inside of the socket, so you slide in completely. But that necessitates carrying around a spray bottle or something like that in order so you can do that. Speaking of that wet fit, that's generally how those sealant suspension systems work too, because there's so much friction between that ribbing and the socket wall. So you need to carry around, you need to accessorize in order to get into it. Once you're in, you can make sure all the air is out. It's still you screw the cap back on, but it's still a one-way valve, so you can do what's called bleeding the socket. So by that I mean, they push the one-way valve to open it to let air out more quickly. Put their weight on so they hear more air come out, release that, and they just keep doing that until they hear all the air come out, and then you know that you're all the way in. Okay. And then, like I said, the sealant suspension system is exactly the same concept as the transtibials. I probably see them more commonly in transfemorals and transtibials, truth be told. And like I said, it's something I usually reserve for somebody's definitive prosthesis once their residual limb volume has stabilized. This is just a transfemoral liner. And here's that vacuum-assisted suction. So there's a tubing that will go to that valve. And this particular one is battery operated, so it actually would draw air out. You can control how much air, how much negative pressure it's putting. And then moving on, this has kind of become, of recent years, more of a hot topic, osseointegration. And so, again, a lot of people have issues with prosthetic fit, with comfort, with the socket range of motion. And so the idea was, well, why don't we just connect something directly to the bone? And this basically would communicate with the outside world, and you would attach something to that, and so it would move right with your bone. This is what you see here is a femur. And so this technology was actually pioneered in dental implants. So people who had teeth or whatever, for some reason it just takes very well, which kind of is counterintuitive because I feel like the mouth is kind of a dirty place. But so they put like these titanium implants or whatever, and they would actually just screw on or attach whatever dental implant in there, and it takes very well. So the idea is, well, if you can do it for that, why can't you do it for something like a larger bone? And so the idea is that they actually put a metal fixture, in this case the femur, within the femur. There's very little, besides soft tissue covering here. On top of that, they let everything heal, and then afterwards they go back and place this abutment from the outside, put it into that fixture, and so now this is what attaches to the prosthesis. So by doing this, you eliminate the need for any sort of socket at all, because it just connects directly to your limb. Your range of motion theoretically is better because you have nothing restricting you in this sense. Your comfort is a lot better. It moves more intimately with you, so ideally you have better energy efficiency. And you can see this connecting piece here. So they basically screw it on and unscrew it whenever they put on, take off the leg for the day. Has been studied a lot overseas, but has not been FDA approved until very recently. It was actually like fall or summer of last year, and only in a very limited population. So it's FDA approved in basically patients who have been refractory to other suspension and socket designs have been done terribly and can't tolerate them at all, and really only approved in the military or VA population. So this is not something you would see in the general public, at least not yet, unless it's in a study or something. So, and here's just a picture of another X-ray of that, and this is with the leg actually fitting on. Again, seamless motion of with the femur, but for all that, the comfort, all that stuff, disadvantages, you can probably guess them. One being infection is a huge problem. I think in the studies that they showed us, anywhere from, I forget the statistics exactly, but well over 25%, probably somewhere like 50 had some sort of infectious issue over 4 or 5 years. And some were more minor than others, but like superficial or whatever. But anything communicating with the outside world, there's that risk of infection, right? Fracture, so somebody who doesn't have good, well-corticated bone, like your osteoporotics, can be a big problem. Not necessarily intended for high-energy activities, because it would put a lot of stress on the bone. And then it's prolonged healing, which is also a huge concern. Really, it takes about 6 months for this to actually be fit. Once you do this initial internal componentry and then the abutment. Because you have to put it in, let the bone heal, and let it take. And so that's a good amount of time that you're not doing, standard weight bearing. There is some suggestion that they try to, it's kind of a fine balance where they're getting it to heal, and maybe a little bit of weight bearing can actually help promote bony regrowth. But so there's that. Okay, so that's suspension systems.